Good afternoon, everyone. Welcome to the session on harnessing big data in radiology health services research. My name is Tessa Cook. I'm from the University of Pennsylvania. I'll be your moderator for this session. It's my pleasure to introduce our first speaker, Dr. Kathryn Lowry from the University of Washington. She's going to speak on application of big data sources for decision models.
Thank you. So I have no disclosures at this time. So for this talk, I'm going to start by reviewing the role that decision models play in the evaluation of diagnostic tests. Then we'll review the different types of decision models and how to select data to inform these models. We'll discuss how to fit models to observe data and how these model results are sometimes translated into policy. So this slide is actually from Dr. Pandarapandi's talk yesterday, if any of you were there, and it reviews the levels of evidence that have been proposed as a paradigm for the evaluation of diagnostic tests. So the first two levels, technical efficacy and diagnostic accuracy, are essentially studies that evaluate test performance. The next two levels, impact on diagnosis and impact on therapy, refer to studies that evaluate the impact of tests on clinical decision-making. And the last two levels, impact on patients and impact on society, refer to studies that look at the impact of a test on outcomes. And so for each of these levels, we have different methodologies and different metrics that we use. So the first two levels, you're probably very familiar with the types of studies and the types of metrics we use because these studies are really important in radiology research. For the last two levels, as you get into the higher levels, we have to shift our perspective a little bit from short-term to long-term. So these studies tend to look at long-term outcomes like morbidity, mortality, quality of life, and cost-effectiveness. In an ideal world, you want to meet all these levels of evidence before you implement a test in clinical practice. And the reason for that is because even if you know that a test performs well, you can't always necessarily assume that it's making a difference on outcomes. And you might ask, why is that? Why can't we assume that if a test is performing well and we're finding more disease, that we're reducing mortality? And the answer is that sometimes it does mean that, but not always. And history has some examples of where we've learned that is not always the case. So one example comes from Japan and their experience with a national neuroblastoma screening program. And this program was piloted in the 1970s in Kyoto City when they started screening infants at 6 months of age for urinary catecholamine metabolites with the goal of detecting neuroblastoma at earlier stages and reducing mortality. And earlier observational data showed that neuroblastoma survival was increasing with screening, and so it gained a lot of enthusiasm. The program was then implemented nationwide in 1985, and by 2001, there was an over 90% participation rate among pediatricians. But then in 2002, there were two really important studies that were published in the New England Journal from Germany and Canada that raised concerns about neuroblastoma screening. Both of these studies had prospectively decided to implement screening in only some of their states or provinces, and then they compared their outcomes in those districts with screening compared to those without screening. When they looked at their results, they saw no difference in absolute neuroblastoma mortality or in the incidence of advanced stage neuroblastoma in the regions with screening compared to the regions without screening. But they did see a total increase in neuroblastoma incidence by about 2 or 3 times. So these results were alarming because they suggested there was overdiagnosis of cancers that would not have clinically presented. Partly due to these studies, we now understand neuroblastoma a little better, and we realize that there's actually different types that have different paths, and probably at least half of them spontaneously regress or differentiate into benign ganglioneuromas. And unfortunately, these were the ones that were mostly being detected by the screening program. The ones that rapidly progress and metastasize were unfortunately harder to detect by screening. So once we understood this, all these screening programs were halted. And in 2004, some Japanese physicians wrote a letter to the editor in the New England Journal of Medicine describing this experience. And they highlighted that this experience underscores the importance of rigorous evaluation of potential benefit and harm before a screening program is adopted as public policy. So how do we evaluate long-term outcomes and prove that an intervention is beneficial? The gold standard, as you probably know, is a randomized control trial that uses mortality as an endpoint. And there have been some examples of really important randomized trials of imaging over the years. Some of them include the National Lung Screening Trial, as well as the Prostate, Lung, Colorectal, and Ovarian Screening Trial. One of the challenges of conducting these trials is that if you're going to use mortality as an endpoint, you need really long follow-up periods. And this is a little bit at odds with imaging because imaging is a field that evolves quickly. And so over the course of your trial, what can happen is protocols, parameters, and techniques can be modified. And then you're a little bit caught between a rock and a hard place because if you allow for modifications to your techniques during the trial, then at the end your results reflect a mixture of techniques. But if you don't allow it, then at the end your results could potentially be obsolete when the study is completed because it's reflecting an older version of your technology. In addition, there are pragmatic and ethical concerns about the randomization of patients to old technologies. And so for these reasons, although randomized control trials are really important, they are somewhat uncommon in medical imaging. And in addition, they are imperfect. They test interventions under ideal conditions, which aren't always easy to translate into the real world. And in addition, they're limited in terms of the number of interventions that can be tested in a single trial due to sample size. So often what these trials will test is they'll compare intervention to no intervention or new technology to old technology. But it's hard to have a trial large enough to evaluate different variations of an intervention, such as testing at different intervals or different durations. So annual versus biennial screening or starting earlier or stopping later. And this poses challenges for physicians and policymakers because they actually do need to include these details in clinical guidelines. So this is where decision modeling can play a role. It is not a substitute for a well-designed randomized control trial, but in the absence of these trials, it can provide estimates of the long-term impact of an intervention to fill evidence gaps and inform health policy. One advantage of decision models is they can integrate data from multiple sources. And they also have inherent flexibility, which allows us to ask a lot of what-if questions. So what if we screen less or more? What if we screen earlier or later? What if test performance improves? What if treatment improves? How do all these things affect the impact of our intervention? And decision models come in various shapes and sizes and forms, but most of them can be roughly grouped into one of the three categories here, which are listed in order of increasing complexity. So we'll start with the first, which is the most basic model, which is a decision tree. And decision trees are appealing because they're very easy to visualize and to follow. The main drawback of them is that there's a relatively fixed or short time horizon, so it's hard to evaluate recurring events or any scenario where there are changes in probabilities over time. So this is another slide from Dr. Pandarapandi's talk showing an example of a decision tree. And in this example, you have a test that's being administered once, so it's either test or no test, to a population that either has the disease or doesn't. So it's a one-time test with a static probability of disease. But let's say you want to evaluate a scenario where you're repeating the test at multiple intervals, or in a population where your risk of disease is changing over time, which is usually the case with cancer screening programs. So for this, we need to add a time horizon, and which is a feature of the next group of models, which are Markov or state transition models. So Markov or state transition models simulate cohorts of individuals over time that are transitioning through multiple states, and the different states that you use depend on the question that you're asking and how you design your model, but in general, most of the states are either a healthy state or a state with disease, whether it's diagnosed or undiagnosed, early stage, late stage, and then terminal states, which are usually death due to disease or death due to other causes. And so we can use these models to calculate overall life expectancy and mortality for the cohort in the presence or the absence of an intervention. The drawback of these models is there's no memory, so you can calculate how long it takes for the whole cohort to reach the terminal states, but you don't actually know how each person got there. And so you can't track the number and distribution of events within the population. So this is an example of a schematic of a Markov model. And so the way this model would work, this is for an example of cancer screening. The cohort would start in the healthy state, and at each cycle, some of the cohort will move to other states. So they may move to the undiagnosed cancer state, and then as time goes on, some of these cancers will be diagnosed. They might be diagnosed clinically, or if a screening module is turned on, they could be diagnosed by screening. They might be diagnosed early stage or late stage. All along the way, the cohort faces risk of death due to competing causes. And for those that reach advanced stage cancer, there's a risk of cancer death. The models are usually run until the cohort has reached the terminal states, and then you can generate a single life expectancy estimate for the entire cohort. But again, you're unable to track screening events or other population-level statistics like incidence of localized versus advanced cancers and age-specific incidence and mortality. So to generate population-level statistics, what we need to do is run a model that allows us to simulate individual people and have memory of each of their events. And that's the last group of models, which is microsimulation. And microsimulation models include multiple types that you might have heard of, such as Markov Monte Carlo and discrete event simulation. But all of these models simulate lifetimes of individuals who experience different stochastic events. They usually try to mimic population heterogeneity by assigning individuals attributes at model entry, such as birth year, start age, and relevant risk factors for the disease in question. And then individual events are tracked and aggregated to generate population-level statistics, such as age at cancer diagnosis and death, mode of tumor detection, so what percentage of cancers or disease were detected by screening, what clinically presented, and screening events, such as number of false positive exams and biopsies. And so this is, believe it or not, a simplified schematic of a microsimulation model. It was given to me by one of my mentors, Dr. Natasha Stout. And so you can see that it gets a little more complex. There's a lot of different branch points of all the different events that can happen. And so an individual enters the model, and a number of ensuing events can occur. They may or may not die of competing mortality. They might get screened. If they are screened, there are a number of results they can have, which all have downstream consequences. One thing to note is that the way this model is depicted, each of these just branch points is a simple yes, no, but microsimulation models allows these branch points to actually be very complex functions. So for example, if it's a cancer microsimulation model, you can make your tumor onset function be a function of age, birth year, and any relevant risk factors. You can also vary the rate of tumor progression so that some individuals in the model have low-grade or indolent tumors and others have high-grade tumors. Or you can have different tumor subtypes, so maybe some tumors are hormone receptor positive or negative. You can also simulate growth, quote unquote, of the tumor over time and link the size of the tumor to likelihood of detection, cancer stage, and prognosis. And finally, you can build in secular trends to simulate changes in cancer incidence, screening, or treatment patterns over time. So one of the advantages of these models is you can analyze results from a systems point of view. So you can look at overall benefits to the entire population, such as life expectancy, quality of life, and cancer mortality reduction. You can also look at resource utilization. So how many screens did you have to perform? What was the number of false positive exams? How many procedures were performed? And what were the overall costs? And then you can synthesize all this information to weigh the benefits, harms, and cost effectiveness and aid policymakers in their decision making. So one really important point about modeling, this is getting into the data part, is that your model output is really only as good as your model input. And so it's really important to judiciously select your data sources for your model. Just some general principles. It's best, if you can, to use large data sets that are representative of the population that you're trying to model. So for example, if you are trying to model cancer incidence and mortality in a population, National Cancer Registry data is a really great source, such as the Surveillance Epidemiology and End Results Program, or SEER. For test performance, it's helpful if you can use a data source that reflects performance in all practice settings and not just data at a single institution. So for example, the Breast Cancer Surveillance Consortium is a source that we use in breast cancer modeling because it's a multi-site consortium that has data from a mix of academic and community practices. For differences in test performance between modalities, if possible, randomized controlled trials are ideal. So for example, DMIST was a randomized trial that compared digital mammography to film mammography. The National Lung Screening Trial compared use of chest CT versus chest X-ray for lung cancer screening. So those are great to use when you're comparing two different modalities. And the more granular the data set, the better if you need to stratify the data into subgroups of interest. So for example, looking at differences by different age groups or differences in risk factors. So breast density if you're modeling breast cancer, pack years if you're modeling lung cancer, and so on. And then just a quick note about other sources of data that we sometimes use in models. For tumor growth and spread, there are mathematical models that have been around for a really long time, but are actually still used in a lot of simulation models that model the rate of cancer growth. For vital statistics or competing mortality risk, the Center for Disease Control life tables are a great source. As new therapies emerged, we usually have to go to the published literature to estimate the effects of those. And of course, there's always expert opinion as well. So once you've selected your data, the next step is making sure that your models actually reproduce this observed data. And this process is called calibration. So what you want to see is, does your model output match these observed data trends? And calibration is an iterative process of varying your model inputs until your model reproduces the known data, and you continue to make adjustments until you have a good fit. So this is an example, again, from Dr. Stout with her breast cancer simulation model. And so in this case, we have a model that is trying to reproduce observed incidence of breast cancer over time by different stages. And so the model output are these purple lines here, and the actual observed data from SEER, which is what they're trying to emulate, are these red lines. And if they had just looked at total cancer incidence, they might have thought, oh, we're doing a pretty good job. But once they broke it down by stage, you could see that the model was actually underestimating incidence of localized and regional cancers and overestimating the incidence of advanced stage cancers. So after an extensive calibration process, they made modifications to the model. So now their model output is this green line, which you can see much more closely follows the trend of the red line. So even when models are well designed and well calibrated, there are a number of drawbacks and criticisms. One is that models are pretty hard to peer review. A lot of these really complex microsimulation models actually involve thousands of lines of computer code. As you can imagine, summarizing all the details in those is a little bit hard to do in a paper or a presentation. In addition, many parameters that we're working with are unobservable and uncertain. And we try to overcome that through the calibration process with known data. But the truth is we are always still estimating some unobservable trends, such as what is the incidence of cancer in the absence of screening, which is sometimes hard to know once a screening program has been in place for a really long time. Or what is the actual time between when a tumor exists to when it's detected. And finally, modeling, in the end, results are always best guess estimates that are extrapolations of data. So you have to be aware of that. So because of this, the National Cancer Institute developed this concept of collaborative modeling. So in 1999, they started CISNET, which is the Cancer Intervention and Surveillance Modeling Network. And the purpose of this network was to use modeling to better understand the impact of interventions, including screening, treatment, and primary prevention on population-based cancer trends in the US. And the network includes working groups for each of the different cancer sites. So there's a breast group, colon, prostate, cervical, and lung. And within each group, there are multiple independently developed models that are designed to project the impact of cancer interventions. And each of these models varies in its design and structure, but they all share common sources of big data that the group has agreed upon. And this collaborative approach allows for cross-model comparisons of results, which allows us to estimate the range of possible effects of an intervention and strengthens the robustness of conclusions, which can then be used to inform practice and policy debates. So this is an example of a recent collaborative modeling analysis from the breast cancer group. The purpose of this analysis was actually to look at the decline in breast cancer mortality in recent years and to estimate the independent contributions of screening and treatment to that decline. But I'm showing this model here just so you have a sense of the range of results that can be produced by different models. So in this case, the white circles are the observed US decline in breast cancer mortality over time as reported by SEER. So each of the models is trying to reproduce this curve. And you can see on the whole, they do quite well. They follow the shape of the curve and are pretty close. But there is a range in estimates from model to model. So like I said earlier, one of the advantages of modeling is that we're able to take a systems point of view. When we present results to policymakers, we're often asked to present both the benefits and harms as trade-offs. And one way to do this is to display the results on efficiency frontiers, which illustrates additional resources that are required to achieve additional benefit. And so when policymakers are choosing a strategy, the optimal strategy involves a little bit of value judgment because it depends on which outcome is most desirable. Are you trying to achieve the greatest reduction in mortality, the greatest gains in life expectancy, or are you trying to achieve an efficient balance of screens and benefits? And usually policymakers are trying to achieve a more efficient balance. If that's what's desired, the optimal strategy is usually selected based on what point on your efficiency frontier you start to see flattening, because that suggests you're getting diminishing returns for additional screening resources. And I'll show a couple examples of that here. So this example is a collaborative modeling analysis of different breast cancer screening strategies. And this analysis actually generated quite a bit of controversy in the breast cancer community. But just to kind of explain how to interpret the results. So each of these is an efficiency frontier from each of 6 different models. Each point on each frontier is a different screening strategy, which reflects either different screening intervals or different ages. The x-axis is the average number of mammograms per 1,000 women. So how many screens are you performing? The y-axis is your percent mortality decline or your benefit from screening. So what you want to see ideally is a line with a steep slope because that suggests you're getting a lot of benefit for a little investment. What you don't want to do is to pick a strategy that's at the end of a very flat curve because that suggests you're using a lot of resources to achieve very little benefit. But as you can see, at what point does the curve flatten is a little bit of a judgment call. And in the end, the task force looked at this data and decided that the point of flattening was this point here, which is biennial screening from ages 50 to 74. And like I said, that generated a lot of controversy. But it's important to point out, again, the models are similar, but not exactly the same. Here's another example of a collaborative modeling analysis with lung cancer screening. So here, this analysis was done after the results of the National Lung Screening Trial were released, and the task force asked the modelers to evaluate the different variations of the screening strategy that was used in the trial. So vary the start and stop ages, vary screening intervals, as well as the pack year eligibility criteria for screening. And I think this is an even more striking example of how different the model results can be. And so what they did in this case, for this frontiers, they have each of the individual models as well as the line in the middle, which is an average of all the model results. And so in this case, the policymaker selected this strategy here, which was annual screening from ages 55 to 80 at the 30-pack year history who've quit within the last 15 years. And note that's actually slightly different than the criteria that were used in the National Lung Screening Trial, which stopped screening at age 74. So just to summarize the points, so evidence of long-term outcomes is important for justifying the use of medical imaging in clinical guidelines and health policy. Decision modeling can fill evidence gaps by synthesizing big data sources and estimating the benefits and harms of interventions and policies. Decision models can vary from simple to complex. Collaborative modeling uses common data sources to provide a range of estimates for long-term impact of medical technologies and interventions, and these results can sometimes be used to weigh benefits, harms, and cost effectiveness and guide policy. Okay, that's it. Thank you.
Thank you, Dr. Lowry. We'll do questions for the panel as a group at the end. It's my pleasure to introduce Dr. Yvonne Lowry from NYU, who will now speak on artificial intelligence as a tool to aid in health services research.
Okay, thank you. It's a pleasure to be here, and I always love coming to the AUR, so thank you for the kind invitation. I'm going to start by talking about radiology and machine learning in general. You guys have probably heard a lot. There's a lot of excitement at the RSNA, et cetera. And specifically, I'm going to try to highlight some applications that pertain to health services research. I'm going to introduce some terminology, and we'll talk about some pros and cons of machine learning, and then specifically the intersection of radiology, machine learning, and health services research. This is an informal poll that we took, a survey that we took within our department, but the response rate was high, over 120 people responded, and you see there's a clear trend of people believing that machine learning is going to change radiology practice over the next decade. So what is it exactly? It's a field, part of computer science that evolved from artificial intelligence. And so this is adapted from Ian Goodfellow's book published by MIT. Where artificial intelligence is a large basket, then machine learning kind of resides within it, and then deep learning resides within that, and we'll talk a little bit about the differences here. And essentially, it's related to Dr. Lowry's talk, where the idea is to try to develop algorithms to understand patterns in data. So within artificial intelligence, generally speaking, there are two main categories: rule-based programming that uses complex, precise instructions. So most of what we're familiar with in terms of how computers work, how Microsoft works, if you click something, something happens. It's based on rigid kind of Boolean if-then logic. And so robotics is something that's essentially rule-based. And then the other category is training, where it's really originally was based on, they were trying to do a simple model of the human brain, and you know, you've probably seen pictures like this where there are these artificial neural networks that people have developed, and we'll talk about how those work a little bit. And I've always be curious about, you know, if you actually combined some of these training and rule-based programming, what would you end up with? Okay, so people draw these diagrams. Essentially, you've got some inputs, you have an output, and then there are these weird hidden layers, what's really in there. So in radiology, we might input an image, and the output could be many different things, and it doesn't have to be binary, like is there hemorrhage or no hemorrhage, but you know, maybe what is the outcome of this person with hemorrhage? Could we predict the quality-adjusted life years even? And this hidden layer is not actually hidden. It is a way of trying to find a simpler representation of the original input. So as a simple example, if you have this data, you want to try to separate the blue dots from the green triangles. If you find a simpler representation, for example, if you use polar coordinates, it becomes very simple that the radius separates blue from green, just a single variable, right? Whereas you probably could figure it out if I gave you the x-coordinate and the y-coordinate and Cartesian coordinates, whether you could guess whether the thing is blue or green. So this hidden layer essentially tries to find a latent or simple representation of the original data. And interestingly, not all representations are actually simpler than the original data, which can be a problem. Okay, so first we started with rule-based systems. We input something, we have a program, we get our output. We're happy with that. In classic machine learning, basically you handcraft features, so you pick certain features, and then you try to map from those features what the output might be. And then in representation learning, that's these hidden layers where we're trying to figure out what these features are. So we have an input, we map to some kind of latent or other representation of the input, and then we try to map from those features what we think the output should be. And then you could have multiple layers where you have simple features first, and then sort of more complex features, and then finally the output. And when you have multiple layers, that's called deep learning. This is an example from Zeiler and Fergus. Is a very famous paper, but basically this diagram shows, you know, if you show the algorithm, this photo, at first, the first few layers take very simple inputs like the pixel level information, and then all these hidden layers deal with increasing complexity as you go up with detecting edges, detecting corners and contours, then trying to detect whole parts, and finally the output is trying to figure out what this thing is. You've probably heard a bunch about something called convolutional neural networks, and that's because they're particularly useful in imaging. So a regular neural network is something that looks like this. You've got all these so-called nodes or neurons, and in these hidden layers, and they try to, you know, so these input onto a neuron in the next layer. So you get inputs from all of these different previous nodes, and then obviously all of these are connected, so then you have this pretty complex connection going around. Now you can see that if your input is one single 2D image that's 256 by 256, all of a sudden you have over 65,000 weights, or basically you can think of those as coefficients for each one of those pixels. And that's just for a single layer. So then if you have multiple layers, it just grows exponentially and could be, just with a few layers, over 1 billion weights. So it's impossible to compute and impossible to solve. So convolutional neural networks is specifically designed for inputting images. And so you could do a 2D or 3D convnet, and basically you put the whole thing in, and you get out a vector, which is a probability distribution of which class something belongs in, whether it's hemorrhage or not, infarct or not. And essentially, it preserves the image, preserves the 2D structure or 3D structure of that original input. And we'll talk a little bit about how it does that. But essentially, it dramatically decreases the number of parameters and decreases your chances of overfitting your model. So what is a convolution? People talk about this in perfusion imaging. You can think of it essentially as an operation between two functions, resulting in a third. So for a 1D example, you got two functions. If you move them together, you could call that thing H instead of F and G, right? And essentially, this is just from Wikipedia, but if you pass this red function, the square wave, over this other function, you get out a different function, which is the convolution of the two. Okay, great. So what does that mean in an image? It's essentially like passing a filter across an image, and you get out this latent representation of the image. Or sometimes people call this like a feature map. There are many, many applications in medical imaging and radiology, in life at large, right? On your phone, walking around, where you're driving. So it's an exciting time, I think, for radiology, and I'm going to touch on just a few of these because it really is so broad that you could apply these tools to the entire universe. We know that in Facebook and whatever apps, facial recognition is out there, does a pretty good job, except it thinks my brother-in-law, my brother-in-law is my husband. But can we learn from that? Well, it turns out we can, but there's some specific challenges to medical imaging. Convolutional neural networks require fairly large amounts of training data, on the order of, there were over 1 million, 1.2 million in this ImageNet data set, which is publicly available. And that's pictures of dogs and cats and bicycles and whatnot. And for us, there are some images. We have millions of images in, right? Particularly if we pooled data across institutions. But there are some data sets where maybe there's specific tissue contrast that you are getting at your institution that it's actually hard to build a database of 1 million images. And then not only do you need the images, you need some kind of ground truth. So maybe you could get Watson to, have 1 million chest x-rays, but then is somebody actually curating every single one to decide, and who is that person then, right? And another trick that people use in computer vision is to downsample, or they call it using pooling layers, but essentially it's downsampling the image resolution. So as you know, we may not want to downsample our image resolution, right? So that you could detect maybe whose face this is, but you can't say anything about, are there aggressive looking calcifications on this mammogram if you downsample too much. Just as an example, this is from adapted from my colleague Christoph at NYU, but he showed this tiny picture all the way in the back of the room. Everyone can tell that's a panda, right? And certainly if you blow it up a little bit. But if I show you this picture, I can't even see, but there are metastases on the picture, right? So, so the strategies have to be a little bit different. All right, let's talk a little bit about different kinds of applications. I like this. My side of the family is full-blooded DOS and Windows, but you are 1/4 Mac with a bit of Linux and Android on your mother's side. In terms of classification, this is just an example from the Swiss Federal Institute of Technology. They tried to separate salmon from sea bass using the weight and the length of the fish. And actually, this is how things are done on commercial fishing boats, okay? So there's an overlap in terms of both the length and the weight, but if you map both of those features, then you can develop some kind of hyperplane that separates them really well. Okay, great. And you could do this with multiple, you can imagine doing this with multiple features, multiple parameters, and in a 3D, but probably infinite number of parameters, and define a hyperplane. And we did something like this with handcrafted features. So we took, we were trying to identify patients with mild traumatic brain injury, which, as you know, is very difficult for us to see the injury. And we used diffusion, kurtosis, ADC, a bunch of different features in different areas of the brain, in the corpus callosum, et cetera. And you see the best feature alone had 74% accuracy, but then when we used lots of features, it improved the accuracy. And if you actually use feature selection, which features are most relevant and non-redundant, you get even better accuracy. Okay, so this is your classic machine learning type of approach with handcrafted features. We picked regions of interest, which metrics to look at, and maybe there were fewer than 100 subjects in this kind of approach. Okay, who's a Fisher person out there? Anyone a Fisher person? So one is salmon and one is sea bass. Does anyone know? The salmon is on the top. I hear someone saying it. It's obvious, right? So if you're a Fisher person, why do you need the weight and the length? That's ridiculous. They look completely different. So we're trying to develop techniques where we could detect this difference, right? And just one approach that we've tried is using this bag of words. It's called bag of words because it started with text, but if I gave you these two documents, you would know right away which one's from a cookbook and which one's your financial statement, right? So in the same way, you could use visual words. And not only can you use visual words, so you cut the image into different patches, you can use visual words, and not only can you use visual words, you can use this latent kind of representation of the patches. So they're not even actual patches anymore, they're latent representations of the patches. And then you can see, well, how often do these certain words happen in different kinds of brains? And in fact, you can see that the ROC curve is quite good for this adversarial bag of words kind of approach. And this is in also relatively machine learning-wise small number of subjects, where we had, I think, 250 subjects in this experiment. And there's no overfitting. You see that the standard deviation is small, and we had a completely held out set, and it had almost the same classification rate. And so these are the histograms. You see that they're just some examples. There are some differences in the number of these visual words that occur in controls versus injured subjects. And this is just the average, again, showing you that there's some differences between the patients and the control subjects. So this is maybe an approach for smaller data sets, which we don't always have the million images, right? But one criticism of machine learning is what are these adversarial features? It's such a black box inside those hidden layers. Can you demystify that? And there are people actually working on trying to give meaning to the different layers. Okay. Oh yeah, I hope everyone's enjoying Orlando. Segmentation is something that's going on in our field, and it can be a tool to predict outcome and other things. So here's just an example there's a contest, right? There are many contests out there now. The brain tumor segmentation, trying to segment the enhancing portion from the edema. And this is from last year, but you can check on the leaderboard which lab is doing well. And actually, it's surprisingly good. So this is an example from my colleague, Chem Denise, where he was trying to segment the proximal femur, and we'll get to why he was trying to do that. But essentially, you can think of segmentation as a pixel-level classification problem, right? So if you could say in each pixel if this is the proximal femur or not, and then color that, then you have this kind of output map. The caveat to the thinking about segmentation as a classification problem alone is that you have to maintain the location of that pixel, right? Because you got to put it back together to form the map. Okay, and what people are using to do this in most recent literature is something called the UNet, which you may have heard about. And it's called the UNet because of its U-like shape in terms of the architecture. But essentially, these are downsampling layers and convolutional layers in a stack. And you can think of this contracting path as a method to extract the important features that would allow me to segment. And you can think of this upward path as the path that actually generates this shape now that we have the features. Okay. And essentially, if we use patches and pixels as our input, then we can tolerate much smaller training data sets, right? Because there are millions of pixels in a small number of data sets. One problem is that there's so-called class imbalance, especially for metastases or something. The number of pixels that are metastases compared with not metastases are very small. So you have to sort of power your whole test based on the smaller class. What are these layers a little bit? Okay. Pooling layers are just downsampling. So it's not mysterious. They are just taking, 2 by 2 matrix and taking the maximum value, and then sliding over and taking the maximum value, so that you are essentially downsampling. It's like when you send a low-res picture, via your phone. And the convolutional network layer we talked about, it's this latent representation. And then it's paired with something called an activation function, which basically tells this neuron what to do based on all of these inputs. And there are many different things that you could use. A step function, either once you're past a certain threshold, you fire. And if not, you're 0. So that's very binary, and there's no probability associated with, well, what if it's 78% you're going to fire? So then people have developed other things, and these are particularly popular, sigmoid and ReLU. But they just have different shapes, and there are pros and cons to each that I'm not going to get into. So, okay, great. So now we can segment it. Who cares? Well, he segmented this because actually he was interested in this, right? He was interested in risk classification for hip fractures, and trying to extract the features that might predispose someone to hip fractures. So in order to do this, the algorithm has to be able to focus on what you want it to look at. And so segmentation, I think, can be a tool when paired with other neural networks, classification networks, outcome predictors. And the nice thing about neural networks is that they do stack really well and easily. And then the other thing is you can sometimes perform tasks together, and it strengthens the training for both. Here's another example. This is from the group at Aarhus in Denmark, and was published in the AJNR in a review article by Greg Zaharchuk. But essentially, they took stroke patients, and they had 2 different neural networks that they had previously trained. And one neural network was using patients who had been given TPA, and the other neural network was trained on patients without TPA. So they thought that maybe they could see what your future was going to be if you got TPA, and then if you didn't get TPA. What about clustering? Nowadays, we know that histology doesn't really correspond to outcome. And outcomes are really tied to molecular subtypes and your DNA. So this is some work that was published in the New England Journal by a big group, and Raj and Jane's one of my colleagues who participated in that. But essentially, you see that gliomas classified according to molecular subtype, the survival curves separate, and if you try to do it by histology, they're all mixed up. So in this paper, they sequenced the entire genome of 300 low-grade tumors, and they tried to detect mutations, and then they tried to do, I bring this up because this is an example of unsupervised learning. So they didn't impose the classes on them. They didn't say, tell me which one's grade 1 and grade 2, or which one has an IDH mutation. They said, well, just learn, put these patients into clusters. And the algorithm, I'll blow this up a little bit, put them into 3 clusters, 3 clear clusters, which went well with the molecular subtype. And you see that the histologic class and the grade of the tumor had almost no bearing on these clusters. And interestingly, from an imaging point of view, because we've known for a long time, we just thought we sucked, basically. We thought we were horrible at predicting the histology or the grade of the tumor, because we were never good. And interestingly, imaging parameters track well with the molecular subtype and the consensus clusters. And this is just one example of many early, 2007 paper, very simple thing showing ADC values, but that separate the GBMs and anaplastic astrocytomas that have poor outcome, poor survival, track with their imaging. There's a lot of work to be done still. This was a paper in Radiology from the Heidelberg group that showed that they did they used handcrafted machine learning, and they didn't think that their classification model could predict the molecular characteristics. But there's new work using deep learning now, which I think shows a lot of promise in trying to differentiate between, let's say, IDH mutated tumors from IDH wild-type tumors. Okay, so in the remaining time, I will talk briefly about some exciting work in imaging. How can you reimagine imaging? We're going to, this is some work that Florian Knoll has given me. How can you train a network to separate true content from artifacts? So if this is the full acquisition, we all want to go faster now. Everyone needs to go faster, do more work, right? So we all know that parallel imaging is great, but multiband is great, but at some level, once you accelerate too much, you get these artifacts. And so can we use a neural network to restore the image, the true image, let's say, and take away the artifacts? So in fact, you can. This is at sixfold acceleration. And then here we trained on all different kinds of body parts, because actually artifacts are predictable, right? They look similar, and it almost doesn't matter what body part they are. And this is a similarity index, and you can see that it's extremely high, especially for high signal-to-noise sequences. Another exciting thing is, can we generate different kinds of tissue contrast? So this is synthetic CT made from an MRI, and this is the actual PET CT, so that we could forego getting PET MR and PET CT for patients who are going for radiotherapy. Here's an example of taking a low signal-to-noise type of sequence, ASL, and trying to increase the signal without increasing the noise. And this is work from Stanford by Enhao Gong. So what about health sciences? Comparative effectiveness research is going up. AI interest is going up. Population health is like the flip side of personalized medicine. Somebody, I can't remember who I heard say that first, but I think that's really true. And this is Pari Pandey. She's a friend of mine from residency, and was mentioned in the prior talk. This is a paper of hers from the early 2000s where they did this decision modeling. What should you do with small renal cell carcinomas, surgery or ablation? All right, so my path went a different way. You know, she saw the value in this when we were residents, and I was trying to model some bicompartment diffusion and look at intra-axonal diffusivity, and obsessed with denoising. And then we found some interesting stuff, which we published, and then we did some Monte Carlo. We followed some folks who did some Monte Carlo estimations. And you can do this with every tissue contrast, right? So perfusion, spectroscopy, there's information coming from many different sequences, many different areas. And then finally, how can you use these together? So I feel that in some ways I took a much more circuitous route, but we're trying to use the data that's out there to actually make a difference or decide what to do about someone standing in front of you. Now, there is a lot of data out there. The EMR claims information, a lot of which is publicly available. The FDA information, there's a couple of big research networks. And then there are images. And these are, machine learning can help because these are very different in how you might input them, right? The data form is very different. And then not only that, we have path, EEG, maybe even the number of steps you're taking. So the advantages of machine learning is that it's high-dimensional data, and it can deal with, it can deal with high-dimensional and high-volume data, and it can deal with variable type of inputs. And it can deal with missing data points, which for some observational, more traditional statistical methods may be problematic. And it kind of automatically considers all potential relationships, and then it also hopefully learns with increasing training data. So in summary, we talked about some terminology. We showed some examples of classification, segmentation, and clustering, and how we might reimagine imaging, and what the intersection is with health sciences research. Thank you very much.
Thank you, Dr. Lowry. Our third speaker in this session is Dr. Paul Cronin, and he will present Translating Big Data Research into Clinical Practice.
Okay, well, thank you very much for inviting me to talk here today. I have no relevant disclosures, and I'm going to talk to you about big data and how that could be translated into research and research into clinical practice. So we'll start off by talking a little bit about how we would define what big data is. I'm going to talk to you about some of the characteristics, including the 4 V's and the 6 C's, and then its role in research, clinical practice, applications, and big data analytics, though not necessarily in that order. So we have to first realize that data is a spectrum. So there's a spectrum from smaller data, so when you do your research project and you acquire data on tens of patients, up to acquiring data on maybe hundreds of thousands or millions of people. So there's a spectrum. So when do we get to call it big data? I'll give you the definition in a minute. We should realize that we live in a very, very, very big data world. So this statistic is already, or piece of information is already a year old, but apparently we are generating 2.5 by 10 to the 30 bytes of data a day, but that was last year, so it's going to be probably, 1 by 10 to the 31 or 5 by 10 to the 32 this year, or whoever it happens to be. So we live in a very big data world. Well, how would we define what big data is? Well, by definition, big data is going to be electronic data, and it's data that's so large and complex that it's essentially difficult, or in fact even impossible, to manage with traditional software and hardware. So we're going to need new software and hardware to deal with this. And it cannot be easily managed in traditional ways with common data management tools or methods. One of the ways to define what big data is to use the 4 V's of big data. So volume, as the name says, it's big data. So it's the sheer volume of data elements that we're dealing with. But other components would include the variety of data. So we're aggregating data from multiple sources. Even with imaging, we can be talking about obviously large data sets of imaging data on your PACS, but also other data that's coming towards you, so from your RIS or your HIS, from your electronic medical record, et cetera, et cetera, et cetera. So a large variety, and then obviously from even outside your radiology department. Velocity, the speed at which data is coming at you. So again, you're performing hundreds and hundreds and hundreds of CT scans or MRI scans a day. So huge volumes of data sets coming at you constantly. So the velocity, and then the veracity as well. So some of this data is inherently uncertain. So the other way that we can think about data, of course, in specifically to imaging, is whether we're talking about imaging data or non-imaging data, and then whether we're talking about structured data or non-structured data. So for instance, structured data might be imaging, non-structured data could be like a free text radiology report. So what are the aims then of big data? Well, the aims of big data are to design algorithms that can run on structured data to analyze it, or in the case of unstructured data, we may have to think about converting unstructured data into wisdom. And what we mean by wisdom is data that's meaningful, clinically meaningful data after we have extracted knowledge and information from the data. So I've talked about the 4 V's. So the 6 C's of data analytics would include connection. So this is thinking about what are the various data sources that you have. So again, this could be things like a physician ordering system. It could be your electronic medical record. It can be your imaging data in your RIS, etc. The second C is the cloud. So again, a lot of this data you are not going to store within your radiology department per se. This is going to be stored on the cloud. And this actually gives benefits in a number of ways. It will obviously free up space and personnel that you don't actually have to have your own IT infrastructure, or the infrastructure that you have can be used for other things. It can be a lot of the time actually safer to store the data on the cloud, where if you have cloud storage, they will have their own safety things in place, and if there's a hacker, a potential hacker or a problem, that can be patched immediately. Cyber refers to the fact that you're going to need large computer processing power and memory. The fourth C is content, so thinking about what's in your big data. Is this DICOM data sets of images? Is it other data? And obviously the content of the data that you're going to search for the information to try and derive the clinically relevant or meaningful information from, to try and correlate this with patient outcomes. Community then is to think about who's sharing the data, who you're collaborating with, etc. And then customization, so the data should be customizable and algorithms available to try and answer these clinically relevant questions. So there's the 6 C's of big data analytics. It's important to say that obviously the data has to be secured. It should be backed up. You obviously have to have the software to deal with this, and you have to have the personnel to deal with it as well. So if we think about big data analytics, conceptually a big data analytical project is kind of similar to other IT projects. The differences would be in how you would process and execute this. So we can think about components to a big data analytics project, and they would include the infrastructure, and again, that's the first 3 C's of the 6 C's. So the components, the cloud, and cyber. We think about the science behind it. We're thinking about extracting the information and then developing algorithms to look at the data, and then using algorithms to extract the data and avail of clinically useful information. So a schema of what we might do might look something like this. So you want to decide, what are your big data sources going to be? So is it going to be internal data, maybe within your radiology department? Are you using data from outside the radiology department? Is this in multiple formats? Is it image data? Is it non-imaging data? Is it structured? Is it not structured? Is it from multiple locations, etc.? That raw data then has to be taken and transformed. If it's structured, that might need less transforming. If it's unstructured, you may have to pool or aggregate this data and then transform it into a way that can be used and it's more meaningful. And then have to think about what data platforms and tools are you going to use. Some of these things are available in the cloud, and there's processes that can be used. And then when you have your data at this point, what analytics are you going to perform? So are you doing things like online analytics? Are you data mining, etc.? So this is a much more complex process than dealing with just the usual data that we're interested in or used to dealing with. So overall, the concept of the project is still, similar to what we may have experienced in other research projects. Again, you want to think about what is the concept statement. These are usually multidisciplinary projects because of the size of the data. Obviously, establish that this is a big data project because of the 4 C's. Think about what problem are you trying to address. Why is this important? Why is it clinically relevant, etc.? And then you go through the process, the methodology of collecting the data, transforming it, thinking about the analytical techniques, and then finding your results and obviously evaluating and validating them. So how can big data be used? Well, it can be used in research in a number of kind of general ways. Clinical decision support, which we've already heard about, disease surveillance, and then population health management. Specifically to research, big data can be used to improve patient care, improve patient outcomes, essentially reduce morbidity and mortality, save patients' lives, and potentially lower costs. We generally have experienced research in a way which is kind of hypothesis-driven. With big data, the difference here is that this is very data-driven. So instead of having, a research project where you're going to look at a disease and a test and see the accuracy of that test, or you're going to compare 2 tests to see the comparative effectiveness of those tests, in this particular case, you're allowing the data to make connections between the test and the outcome. And the advantages here are that traditional research projects that may be looking at that test test accuracy or even trying to connect with test outcomes can be difficult, they can be expensive, they can be time consuming. Obviously one way to get around this is modeling, as we heard. But again, that's a model as opposed to real life. What big data can let us do is obviously process large amounts of data, large numbers of people, seeing what's happening in real life. So that also gets over some of the issues around, the randomized control trial or the trial being the absolute perfect thing, but not being able to translate that into real life because there's the messiness of real life. And with big data, we kind of let some of that messiness happen. We allow the patient have the test. The test may be positive, it may be truly positive. The test may have false positives or false negatives, and you allow some of that happen, and you just allow it be data-driven to make the connections between the test and the outcome. Advantages to healthcare in general would involve predicting patient outcomes, potentially identifying patients who are less likely or unlikely to benefit from expensive testing or treatments. This has the potential to have large savings to the United States or other healthcare systems, and it can also directly help with clinical operations and research and development, and we can look at some of this. So with regards to clinical operations, big data can help comparative effectiveness research to determine more clinically relevant or cost-effective ways to diagnose and treat patients. It gives us the ability to maybe determine what are the best tests to perform and maybe in what order. So again, you know, we think about the idea of patients coming in with symptoms of a potential disease and we do a test. Life, of course, is much more complex than that. Sometimes tests are indeterminate, and then we might want to predict what's the next test to do, or what's the best order to perform the test, or in certain patient populations, what testing orders can be doing. So we could think about pregnant patients might need different order of tests or different tests than non-pregnant populations. Big data can help us potentially within research trials lower attrition from trials and produce kind of leaner, faster, better trials by using predictive modeling. We can also improve overall our trial design. This may lead to better patient recruitment and retention, and reduce trial failures and speed new technologies to market by using statistical tools and algorithms. We may be able to, within trials, identify follow-on indications or discover adverse events more quickly using analysis of clinical trial data and patient records. With regards to public health, it gives us the ability or the potential to improve public health and the better response by analysing disease patterns. And potentially just, again, lead to the development of better technologies and to do this more quickly. Again, within public health, big data gives us the ability to identify potential needs and provide services for those needs by turning large amounts of data into actionable information. We can also combine and analyze both structured and unstructured data from the electronic medical records to better match technologies with outcomes, and then potentially predict patients who are at risk for disease and potentially screen those patients or investigate or test those patients earlier and get a more early diagnosis and therefore provide more efficient care. Other things that we can do is identify patients who'd also benefit from a more proactive investigation or more from preventative care by looking again at advanced analytics in patient profiles. And then things that are outside imaging per se, but maybe kind of adjuncts to imaging, such as looking at genomic analysis, gives us potentially the ability to identify abuse or waste and prevent this. And then, of course, there's the issue around remote device monitoring, which again is maybe a little less relevant to imaging. So it's important to realize that in radiology, we are people who have lived in a digital world for maybe longer than a lot of other physicians have. PACS systems are over 30 years old, and that's not necessarily the case in other branches of medicine. So we are potentially kind of ahead of the curve in the sense that we have been dealing with data for much longer. We've been dealing with big data sets, and in most radiology departments would have a pretty mature information technology infrastructure. What are potential applications? Well, we can think about a number of applications, and these would include things like image interpretation leading to personalized diagnosis and management recommendations, using big data to identify new diagnostic information, identifying the value of an imaging test, and then optimizing and improving our radiology workflows. So if we go through these, if we think about what we do as radiologists, we often look at an image. I'm a cardiothoracic radiologist, so I might see an opacity on a chest CT, for instance, and I might process some information. I will look at like lesion-specific things, maybe its size or its shape or its intensity or its attenuation. And I might think, well, in a younger patient, it's more likely to be an infection and check what their white cell count is. In an older smoker, maybe this is more likely to be malignant. But there's only so much information that I can, put together in this Bayesian analysis. But big data allows us to synthesize large amounts of information, lesion-specific information, patient-specific information, and even population-specific information to potentially give a better diagnosis, and then potentially give better management and treatment and follow-up recommendations. So as I said, we can think about things like the morphology of a nodule or something like that. I can add in maybe some patient information, demographics, information from a physical exam, laboratory information, but I can't necessarily add in all that information in genomics where big data can. And it can, for instance, data mine information from nodules in the National Lung Screening Trial that would give us a much more accurate ability to predict what the probability of this nodule is, whether it's benign or malignant, or even if it's malignant, maybe what the histological subtype might be. It might give us information as to what we think the best treatment could be. Should this patient go to surgery? Should they get radiation? Should they get chemotherapy? And how best should we follow them up? Or maybe what research trials are even available for this patient to participate in. Thinking about identifying new diagnostic information. In general, again, what we do as radiologists, we're looking at imaging, and then we issue a report. There's a lot of information that's lost in doing that. And certainly if you were to look at reports that have been created by a radiologist, a huge amount of information is lost, and it certainly would be very difficult potentially to make connections between findings in imaging and maybe identify a new imaging biomarker. Even looking at tens, hundreds, maybe even thousands of images, it's still going to be particularly difficult to maybe make that connection to identify a new imaging biomarker, and particularly difficult maybe at a single institution, etc. What big data can do is obviously take large data sources, often multi-institutional, and potentially identify subtle changes or changes that could potentially act as an imaging biomarker. So if we look at this diagram here, we can think about, we could have imaging data. We may tag or identify an abnormality. There may be automatic processing that could identify changes within an image. We can also put this data together with laboratory data, so clinical laboratory findings, proteinomics, genomics, clinical information such as physical exam, past medical history, family history, etc., and put all this information together. Currently, there's a Alzheimer's disease neuroimaging initiative that has done this. It's taken MRI images of the brain, it's added this other clinical information, and doing things like making volume estimates of the brain. It can actually very accurately predict what people's chances are of progressing to mild cognitive impairment and dementia with relatively high accuracy. And then when you add in a follow-up scan the next year, again, you can refine this. So looking at the value of an imaging test, big data maybe has the potential to identify, to essentially tell us what the value of a test or an intervention is. The value of a test is obviously the incremental benefit that we get relative to the incremental cost. But this can be difficult to identify. Again, a patient may have one test. If that test is negative and truly negative, that may obviate the need for additional tests or visits to physicians, etc., and that may save costs. But of course, the test may be inconclusive, and it may lead to more testing that may cost more. So big data allows us maybe connect that test result action outcome chain more accurately. It gives us the ability to potentially identify negative tests that may still be very valuable even though they're costly. A test that is a high negative predictive value that could maybe stop further testing may have a lot of benefit, whereas testing that isn't so expensive but maybe doesn't have a lot of inherent information may be less helpful. And we look here, obviously, as we do a test, there are a number of outcomes that the patient can have. So we could have, for instance, a suspected diagnosis, and then we could have the potential benefits and costs. Now, testing can also then give us an alternative diagnosis, and we could look at the benefits and costs of that, or even to identify an incidental diagnosis and look at the benefits and costs of that, and then see what the true benefit or versus cost of an imaging test is. With regards to helping how we actually work, big data has the ability to help us work more efficiently. As I've already said, there are multiple different data sets within a radiology department. They're large, they're different. It can be difficult to get these to talk to each other. They can become fragmented. They often are siloed. And big data helps us to potentially integrate this information better. It also gives us the ability to potentially look at metrics that we haven't been able to look at before. And often we will measure things because they're measurable, not necessarily because they are the most important thing to measure. But big data gives us the ability to have a much larger range of performance metrics that we might want to assess. And in this schema here, we can see that there's a lot of different sources of data, from health information exchanges to the electronic medical record to the radiology information system to PACS, etc. And then big data at all of these points can be helping us. We can be data mining, we can be getting more information, and then better integrating these systems, and also assessing these systems and looking at more meaningful metrics. This slide here just goes through some of the areas that big data maybe can potentially help us, in areas that are, maybe come into a radiology department relatively soonish. The first thing is talking about a more smarter, intelligent risk, which is something that I've already talked about. So we may have the potential of more intelligent planning or scheduling and delivery of patient-specific instructions, both prior to imaging. We could have a race that could better schedule patients, make sure pregnant patients have a pregnancy test, or women of childbearing age have a pregnancy test, I should say. Trigger so that a patient who is coming for a cardiac MRI would get a chest radiograph to make sure that there isn't a retained foreign body, etc. After imaging has performed, big data can help us in decision support, so there's the potential for computer-aided diagnosis, computer-aided detection, pattern analysis of images, potentially to identify things like ground glass opacification or fibrosis, and potentially help us with the diagnosis of interstitial lung disease, or a specific diagnosis of things like non-specific interstitial lung disease. Big data can also help us with serial accurate size or volume analysis of tumours, and help us determine whether tumours are growing or staying the same or reducing in size. Data can also act as a quality assurance tool. So there's the potential to make sure that an organ has enhanced appropriately, so that we can see lesions, identify areas of abnormal density or intensity that maybe the radiologist wouldn't necessarily have seen, and can act as a quality assurance tool. There's potential in emergency imaging as well to potentially diagnose subtle pneumothoraces, bleeds, extraluminal air, etc. And then to help with things like maybe bone aging, where there's a lot of intra-observer variability, to be a more accurate give a more accurate diagnosis in areas where there often is quite wide inter-observer variability. So I think we're getting a little short of time. I'm going to stop here. I would like to summarize by saying that big data, I think, is an important area that has many advantages to the practice of radiology, and I'm happy to take any questions. Thank you.
I'm going to ask all our speakers to come up to the podium, and we'll take questions from the audience. So I have a question for all of you. We've talked about big data, and Paul alluded to the fact that one person's big data may be another person's medium data. How much data is big enough data?
Well, I think the 4 V's are, consider the definition of what big data is. So, velocity doesn't, it isn't defined as to, but I think, again, it's one of those things you get a feel for, the size of the data set and kind of how quickly it's coming at you and that type of thing. So again, it is a spectrum, but if anybody else has another opinion, I don't think there is a hard and fast definition of, there's a cutoff here and that constitutes big data. And maybe
I would ask, what's enough data?
Right, I think that's my question.
And it totally depends on what your question is and what your input data, how good it is, how complete it is, whether it reflects the whole population that you need to study too.
I agree. It's not just the size, but also does your data reflect the population that's of interest to you that you have to consider as well.
So one question, Jerry, you can go first. No, thank you for that great session. I'm not really expert in AI or big data, but so when the data is, you said that the Yvonne, that you talk on the unsupervised learning. So if data is not curated or annotated, you obviously need a large data to extract a nonlinear relationship of data and output. But if you curate, annotate, then you may not need to have a huge data. And where are we in terms of using the technology? I mean, obviously AI can be workflow issue, could be some sort of, packs and easy to get the hanging protocol, all that stuff. But when you try to use the AI for clinical diagnosis, imaging diagnosis, what would be the process to use the AI for diagnosis? I mean, is it better for us to train the data in a way that the more curate data and then put it into some sort of AI toolboxes or black boxes to get a diagnosis, spit it out? Or should we just dump all the data and unsupervised in a machine to figure it out? What is the sort of direction that we are heading, if you have any thought?
Right now, most people in computer vision and data science are working on supervised learning, right? Where things are, so ImageNet, AlexNet, everything is carefully curated, or not so carefully curated. They're curated by like students who are tagging things. So I think there are a lot of efforts in that area by various groups, including vendors in our industry, to try to tag all kinds of images. I think it depends on the application in terms of how many data sets you need and how accurate the algorithm is and what you're asking it to do, so that you might get good results with a smaller data. I mean, I didn't have time to show it, but I have some slides just about what do you do when you have smaller data sets and what are some of the things you can do. So people are trying to generate data so they can take an image and then they'll rotate it. We're like a brain tumor. If you flip the image, maybe that doesn't exist in somebody, but that would also be a brain tumor if it came through, right? So if you flip the image, you crop the image, you rotate the image, that can boost your efficiency. And then there are people who are trying to really synthesize new data, right? And then you run into whether this is, how real is this? Is this hallucinatory, or can I really trust this? And how can we train the algorithms to generate data that is anatomically and physiologically appropriate, right? So I think there are some strategies that people are just trying to develop to deal with smaller data sets. And you don't need a lot of data sets for certain applications like segmentation, because if you do it on a per pixel level, right?
I have one more question, completely differently. Paul, you mentioned that we have tens of megabytes of data, image data set. But when we come to radiology and we interpret, it becomes 100 kilobyte or few words of a report. So how do we get that radiology report into this data element? I mean, right now it's still very narrative description of no evidence of blah, 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 or cannot be excluded. Is that the natural language processing is the only way to get the data extracted from radiology report into the data element?
So, there's a couple of ways of looking at this. Yes, that's one way. The other option is to not use, what we've historically used is looked at reports, but is to obviously not use the report to go back to the image, because then you don't have the loss of information. And then use big data techniques to actually look at images themselves, as opposed to relying on the radiology report, because there's just too much truncation of information. You can also use the report. The problem is that the report is unstructured data as well, and it's difficult then to extract meaningful information from that.
And structured reporting helps
Yeah.
to a degree, but you can also have a very unstructured and yet structured report in terms of the content that you want to extract, so. Jerry?
So first I want to thank the speakers for the fabulous job they did in taking a really complex topic and making at least me think I could understand a lot of what was being discussed. I wanted to ask about one of the V's, veracity, that Paul had mentioned. And Katie had said that models that you build, of course, are only as good as the data that populate them. As we deal with larger and larger data sets, especially pulling data directly from the EHRs, we all know that there's a lot of garbage in there and a lot of things that aren't true. And I'm just sort of curious as to how you dealt with it when you are dealing with these large data sets. What's the magnitude of this problem in your opinion, and strategies to overcome it?
I don't really have a feel for the magnitude of the problem. I think probably within imaging, it may be less of a problem than in other areas of medicine or outside of medicine. Particularly if we're relying more on imaging data and stuff that's coming through our wrists, it may have that V may be less of an issue.
Of course, if you're dealing with building predictive models that take into account not only the imaging data, but all the ancillary data that surround the imaging, you do have to deal with it.
Yeah.
Yeah, I think it's a limitation. I think what the net result is that we have to put kind of asterisks by our results and say, this is our best guess, but it's limited by what we have.
And people are also trying to develop some algorithms where the machine detects the things that it's most unsure about. So, like an example is handwriting, numeric letters, detecting what numbers someone's writing. So instead of trying to classify or trying to feed back every single number, it only feeds back the ones that it had low probability of figuring out what was going on in the first place. So in that way, it actually helps the algorithm because it's more streamlined, it's faster, because it doesn't have to deal with all the numbers that it was pretty sure about. And then tries to specifically manage that muddy ground where the input, like the handwritten number, was sort of a mess. So I think people are trying to think about how to almost automate improving the veracity.
So I'd just like to add one comment to that. I think one of the realities is as we think about veracity, we have to think about what the comparator is and what we are talking about in our expectations. So, if we think about the self-driving cars, an example of machine learning, and people have died at the hands of a self-driving car. Well, people are dying when humans are driving cars right now. And so the idea is that there are still going to be
We have time for one last question.
So my question is, in your experience, what's being done out there to share data amongst institutions, and what should be done versus what is being done, like shared PACS systems or just calling your buddy in California, asking him for a bunch of head CTs? What's going on out there, since the problem usually is not enough data?
I mean, certainly cloud computing gives us the potential to share data more. I mean, that's certainly one advantage, because there's the ability to take data from multiple different places and aggregate that data, wherever the server is that the data is being stored. So that certainly gives us the ability to accumulate data and look at data from multiple different data sources. It obviously brings up issues about, who is willing to collaborate and whether people are willing to collaborate their data.
I think
about IRB and a HIPAA compliant issue?
Yeah, there are issues around that. I wouldn't claim to be an expert on the legality around that, but.
I think
How about the ACR Data Institute? Have you heard about that? Like ACR,
Yes.
Data Science Institute? It seems that they have a great idea. I just don't know how, are they working on that?
yeah. So that's a new. I think Bruce Hillman's in the audience.
I think it's an area that we're working toward. I don't know if there are others that we have as a definitive, here's what we should do. Mostly I think because we see a lot of different models and what people want to do based on some of the different legality issues of who actually owns your patient data organization, the different patient consent forms we currently have out there. I think there's a few different aspects we see. One is individual institutions on their own that might just want to, like, if they're really large, and we see some folks doing this already, just saying, we're going to create an avenue that we can get this data out there and get access to it. I can also see consortiums are forming institutions or institutions for different societies out there as well, to say, this is a society wants to help do this. And I think there's different ways of doing that too. Do you want to have it so it's fully publicly available, like you try to scrub the identification off of it and then just make it available for everyone? Or do you have some sort of paywall or legal system that says you have to sign these documents and then we'll let you work inside of ours? We discussed long-term too of like if the ACR or some of the other big societies like that too should also provide their own platform for folks who don't have the resources to do this or not. So there's a variety of ways of hitting it. I think we're earlier on in saying, here's, the definitive paths folks can follow right now, but it's definitely an area that we're pursuing to help give further guidance and clearance on.
Yeah.
That was a non-answer answer.
From the perspective of the journal, the JACR, we're in business. We've announced that we're very interested in publishing good data science papers that particularly that will bring the readership, 30,000 readers of JACR, up to speed on, I thought these three talks would be actually very good for the journal.
And just to add something to Chris's comments, so there are multiple efforts going on, sponsored by different societies, for creating large, high-quality labeled data sets. So many of you may be familiar with the Pediatric Bone Age Challenge that the RSNA did last year. I think they're looking to do something similar this year. SIM, the Society for Imaging Informatics and Medicine, is also working on a labeling project. So there are multiple types of initiatives going to answer that last question, and we'll have to see how these data sets are eventually curated and made available. But please join me again in thanking the speakers for a really nice session, and thank you all for attending.